Hi, everybody, and thank you for giving me this opportunity to present, to give you a little idea of what we do in our TB program here at the New Jersey State Department of Health. I just wanted to start out with giving you a little bit of numbers for our TB morbidity in New Jersey. As you see, it stays pretty stable. It's been pretty stable over the last few years. You see that big dip in 2020, and that was a national dip, about 20%. We figure somehow it was related to COVID, but now we see our numbers are going back up and we'll probably, stay at that trend. And we go down about 2% a year, our numbers. This is just to give you an idea over the years where our TB is concentrated. In some of the counties, we have some higher incidence in the central and northern counties. And then as you go a little bit south, we have a little bit less incidence of TB. And this map kind of highlights it for you. And you can see Middlesex there has greater than 200 cases. And they're one of the higher incidence counties. This is multi-drug resistant TB numbers. Our multi-drug resistant means they're resistant to rifampin and INH, which is our two best medications that we use to treat TB. So they're a little bit more difficult to treat. It's not that common. Last year, we had a big jump that I don't know what happened there, if it was any related to 2020 with people not getting evaluated, but we usually stay on the average of, 3 or 4 a year. So why we have these TB services, I'll give you a little background of where this all comes from. New Jersey is a decentralized state. There's 21 counties that are divided into 565 municipalities, and this is all broken down with 94 local health jurisdictions. And the reason that we're bringing that up is because each of these local health jurisdictions are required to have some core public health services, TB being one of them. So most of the funding is funded with municipality tax dollars. That's why TB services are required and there's no charge for TB services, but I'll explain that a little bit more. And then some of the services are funded by the New Jersey Department of Health. There is required by the practice standards of the state sanitary code that these services be provided. There's a bunch of services that are provided, and I know a lot of you work in a lot of different areas here, but I'm just highlighting that one of the required practice standards by the sanitary code is the diagnosis, treatment, and follow-up for tuberculosis and sexually transmitted diseases. This is our NJ State Department of Health TB program site. And if you need some information, this is a good resource for you to go to if you need any more statistics or any kind of forms and stuff like that. And just move this because I can't see my own slides. Okay. So the TB control program supports a lot of control activities in the terms of clinical evaluation, treatment, prevention, and epidemiology. We do this at the county, municipal, and institutional level through provision of health service grants, staff, medication, consultation, and education. So I'll explain a little bit how that works in surveillance, field support, financial support, education, and nursing support. We get a lot of calls from different clinics asking, what is the state's regulation or policy on this? And we're not really in the mindset of writing regulations or policies. That's not really what we do. These are the services that we really provide. And I'll again get into a little bit more of that. TB, anyone that's a TB suspect or actually confirmed tuberculosis has to be reported. It's a reportable disease. The local health departments report TB suspects, cases, and contacts to the state health department, and the state health department in turn reports that to CDC. The local health departments also follow up on what we call B-immigration. That's reported to the state through the Division of Global Migration and Quarantine. So we might be a little bit different than some of the other communicable diseases, because most of the other communicable diseases, I believe, get reported first to the state, and then it trickles down to the counties. But to expedite patient services and care, especially if they're hospitalized, the TB program has the local health departments usually get that first report from, it's usually a hospital, and then they will take that information in and send it back to us, up to us. And except for the B immigration, that'll come to the state first, and then it trickles down to the local counties. Our B immigration is anyone that wants to migrate to the United States, and they get evaluated in their country by panel physicians. And if there's any, TB being one of the screenings, and if there's anything that suggests that they might have TB infection or potential issues with TB in the future, they're reported to the health department, and they have to be followed up once they get here to the United States by the local county that they reside in. Just to give you some timelines, a diagnosis of confirmed or suspected TB has to be reported within 24 hours or within 24 hours of initiation of treatment. We need 24 hours notice if there's any inpatients that's posing immediate threat or a public health risk. That would be somebody that's threatening to leave AMA, somebody that says they have a plane ticket or a bus ticket, or, you know, they have to get back to their country. These are what we can consider immediate public health risks if they're infectious. So most of the rules and regulations that we do follow fall under the New Jersey Chapter 57, Communicable Disease Regulations, and we're subchapter 8. So the purpose of Code Title 8, Chapter 57 is because tuberculosis is a communicable disease, we do have some public health laws that do, we can initiate if there's certain things that are threatening or a threat to the public. Who's responsible for providing these services and making sure this is all carried out? Well, the healthcare providers are, you know, responsible for the outcomes and having patients safely discharged into the community, as well as hospital administrators, public health nurse case managers, which we have one in every county, and correctional facility administrators, because when TB patients are in a correctional facility, they have their own medical facilities within the correctional facilities. So it's important that they know that there's certain standards that they have to follow to keep our public safe from the spread of tuberculosis. So it's one of the ways that we give financial support is all the TB medications for any TB case, contact, or anybody considered high risk for developing TB disease get medications free through our state. We provide all of the supplies for testing, contacts, and other high-risk groups. We use, besides PPD, their clinics use T-spot or QFT testing, which the T-spot and QFT testing are blood tests that are now able to detect TB infection. And actually the test is called an Igra, intergamma release assay. And there's two registered trademark companies that provide those tests, one T-spot, one QFT. It's quantiferon. So when you hear Igra, it could be either one of those tests, but the test is actually what we call an Igra. We have a public health laboratory that at no cost processes the laboratory specimens, usually sputum, for microbacteriology. We do provide rent assistance for TB case patients placed on home isolation that can't maybe work, or they were no longer welcome back to the residence that they were staying because now they have TB, which is not uncommon. We provide incentives and enablers to promote access and adherence to TB therapy. An incentive would be we get like Walmart cards, ShopRite cards. So if somebody has some issues and needed a little help with something, we can use it for that. Or the incentive could be, you know, we watch you, we do direct observed therapy, which means we watch the patient take their meds every day. And if you do that every day for 5 days, you can maybe get a gift card, and that kind of helps us get people through this treatment, especially if they're having issues or side effects and not wanting to take the medication. Enabler could be bus tickets, and anything that enables them to, you know, finish their therapy. We also provide interpreter services for our non-English speaking patients. So the funding that we get from the state, we get funding from the state health department. We also get funding from CDC. And how we broke that down as far as the funding is we have 6 regional sites. And try to fund 21 counties doesn't really work. So we concentrated on funding the regional sites. And a regional site means that anybody from any county can utilize that site for their TB patients. We did that, or the program manager at the time that did that was because if you go down South Jersey, when you see the numbers, or maybe up North Jersey, they don't have as many cases, and they might not have the expertise because they don't see as much TB. So instead of them having TB clinics when they may never even have a case, like Salem may have a case once in a while, but not all the time. Now they do have a nurse that's overseeing the TB services if something pops up, but in those cases, we would send them to Camden, anyone south for our regional clinics. We have a regional clinic in Middlesex, Hudson, Lattimore, Morris, and Somerset. And those clinics, the medical physicians are what we call our TB experts. They've been doing this a long time, and they see TB patients, that's all they do in our regional clinics, is see the TB patients. We do provide transport for TB case patients to the regional TB clinics when there's no other options are available. So, if you have patients down south that need to get to Belmore, that's kind of difficult sometimes for our patients to get, even to our clinics that are in the same county. But for them to get to some of the regional sites, it might be difficult. So we're provided with state vehicles, and one of the purposes of those state vehicles is to be able to transport patients. We can assist with direct observed therapy. Like I said, prior to COVID and, prior to all this new technology, direct observed therapy was somebody literally going to someone's house every day, 5 days a week, for their job, to meet them, to watch them take their meds. And that sometimes was not feasible if there was short staff or somebody went on vacation. We would always assist with that. Now we have a lot more technology, so a lot of our patients are being seen via video, DOT. And we also offer direct support, whatever that might entail. You need help getting reports done, or you need help with anything in the clinic, we will be happy to come out and do that for you if you need. We also provide a lot of education. We provide technical assistance. I get a lot of calls from health departments or local health departments with questions. I'm very lucky that I've been doing this a really long time, so I have a lot of resources where I kind of know to get the answer. So maybe to give them that technical support of answering that question, or give them the link to the information that they need, that they might not know where to go get it. We do a lot of community education. If there's a need for any kind of education out there, school nurses, hospitals, anybody that thinks they need a little bit more insight into TB, or like today, we are happy to go out and to do that. We also assist with congruent setting educations. If there is a TB in a work or a school, a lot of times there's a lot of panic about that, and we will go out there and do an education session. And we find that at those education sessions really takes down the heat of people being very panicked about there being TB in a school or their workplace. We collaborate a lot with the Global TB Institute. The Global TB Institute is in Newark. They service the whole Northeast region. For education specifically to TB, they're considered a centers of excellence. There's 4 in the United States, and we're lucky to have that Global TB Institute right here in Newark, New Jersey. So they offer a lot of classes, and if you go to their website, they have a lot of products and free products also, and webinars and stuff that are archived. We also give nursing support. That means it could be clinic support, education, patient interventions, or clinical consultations. Right now, if there's sometimes clinics have nurses that are out, or they have whatever issue and they need some coverage in a clinic, give me a call. Really happy to go out and get my patient care on. I sometimes miss patient care, so being invited to help out in a clinic is always a pleasure for me. Or to do education, or we'll get calls about, patient interventions. It's always good to brainstorm. Even doing this for a long time, sometimes, I'll call other colleagues or staff members just to brainstorm and say, hey, I got this patient, like any ideas, because they're all so unique that, I think it does sometimes take a village to get some of these patients through, and you might not have all the answers, and that's what we're here for. Let's work it through. And we also do clinical consultation. People will call me and they're like, I'm really sorry for bothering you. And I always tell them, it's literally in my title. My title is nurse consultant, and that's my job, is to consult with you guys. So feel free to reach out for any questions, big, small, little, again, just to brainstorm. Happy to do it. So I just wanted to tell you a little bit about what our case managers do. Like I said, there's 21 case managers out there, at least points of contact. Not every county has TB programs if they're smaller, but they have to provide TB services. So the TB services that every county or health officer that's out there has to cover is what we just talked about, nurse, field, DOT. So if they cannot provide that, or they don't, if every county and those 94 municipalities tried to have a doctor or a TB clinic, it would really get a little bit hard to do. So they can contract their TB services through, some of the regional sites or through other services, and that's done in some of the different counties. But the ultimate goal is we have a contact person in every county, and the goal of the case manager is really to make sure that we start with the hospital. That's where we find most of our patients, is in the hospital. We want to make sure that there is uninterrupted care. There's a nice smooth transition from the hospital to outpatient settings without, there being any vulnerable populations in the home, or a patient being discharged without our knowledge and don't have meds or need meds. There's a lot that goes on getting that discharge done. And we want to prevent the disease progression. We do that through our contact investigation. So one of the things that we do when we go interview a patient initially is we start on that, getting, who's your contacts and getting them tested to stop the progression. Sometimes we find other cases in a home that, but for the most part, we're looking for anybody that has infection when we do contact investigation, so we can get them on some kind of preventive treatment. And we want to stop drug resistance. Drug resistance is prevented basically by doing DOT. These patients are minimally on treatment for 6 months. In the beginning, there's like 10, 12 pills, and sometimes the side effects aren't so great. So, we don't want people playing around their meds, not taking them, skipping them, eliminating some that make them sick. We all do it, right? We all do it. Even as nurses, we probably skip stuff when we shouldn't. So that's how we prevent drug resistance, is by doing DOT. We also want to make sure that they are all receiving their TB care and treatment by the standards of care by the ATS CDC IDSA, which was updated in 2016. So when these reports come in, we look at them. It's important to know that they're on the correct regimen. It's, the regimen is in accordance to these published standards, and we want to make sure that everything is coordinated. We don't want any fragmented care. That's kind of why the TB nurse case management got started in the early 90s, because there were deficiencies in programs, because things were falling through the cracks. So nurse case management has been around for a while, but this is just the things that we do for TB are specific to TB nurse case management. And the case managers are responsible not only for the TB suspects and cases, but they are responsible for the family, the contacts, all that, anything, their work site, if there are possible contacts. And when we find contacts, it's not just about getting them tested. It's important to do the education, to tell them that if they're positive, why they got to get on treatment, and then follow them to make sure that they finish treatment. We had a multi-drug resistant patient years back when I was working in Middlesex, and they had 14 people in the home, and a lot of contacts, a lot of positives. And there was a handful of them that just weren't finishing. We did our due diligence. We'd say we drop it off at the house. We tried to get them to finish. They would not, they just didn't. And 5 years later, we ended up 3 new MDR contacts. So it's just as important to get out and make sure those contacts finish their treatment, because we don't want future cases, and you will see future cases come back. We want to identify any barriers. We want to do that right away. We do that as soon as we go to the hospital. You know, is there any barriers with them going back to their home? Or are they out of work? Do they have food? All these things, you know, there might be new diagnoses that come up that they didn't know before. Now they might be diagnosed with diabetes. All this has to be coordinated. So we ask that the TB patients be reported in 24 hours. And once we get that report, we it's actually in the regulations that the nurse case manager that needs to go out within 3 days to start getting this information, because it's not, the hospitals always do want patients to get out of hospital, of course, but it's not fair to the hospital to say we can't discharge them because I haven't had time to go and do my contact investigation. But one of the things we do when we go there, we get the contacts, we got to get the address, we got to verify the address and make sure that they can go back to that address. We got to get a DOT plan. We don't want our patients being discharged with medications because they get it for free. And if you give them scripts for meds, it's a couple $100 that most of them don't have. So we have to coordinate that we, as the nurses, get a doctor's order. So when they are out, we can go to the home and start them on DOT and then get them into a medical appointment, either with one of our clinics or make sure they have one with their private provider. So this is a really good resource. I feel this is our Latent TB Infectious Guide for Primary Providers. It lays out all the treatments for latent TB infection. Everything TB seems to come back to the TB clinics. So we'll have ID docs out there that'll be like, oh, you've got a positive Igra, positive PPD. They'll get the x-ray and say, okay, you go to public health. And that's really not the way we want to go. We really are going to need to get primary health providers on board. If a third of the world is infected with TB, public health is not going to be able to end or eliminate TB without private providers jumping in when they can to help us treat latent TB infection. So a lot of our clinics don't treat latent TB infection for anybody, just everybody, because they're concentrated on the cases, the contacts, the immigration, the people that we know are at high risk of breaking down immediately. So if you, and it depends on the county, you'd have to check because everyone does it a little differently depending on their resources. But if people are getting tested for employment or for any other reason, we do take school children, but if they're getting tested for employment and they're saying, okay, go to your TB clinic, they might not be able to be seen at TB clinic because we wouldn't be able to take care of all the cases and contacts in our higher incidence clinics. So get the word out to your private primary providers that, yeah, hey, you could do this. And it's getting better because we have new treatments now. I can understand private providers saying, oh my Lord, I have to treat these people for 9 months and all these appointments coming in and evaluating. Well, you know, we're really getting away from that INH of 9 months. When INH first came out, it was a 6-month treatment. Then somebody did more studies and they said, hey, if they take it for 9 months, there's less likely that they're going to break down with TB because nothing's 100%. So if they got 6 months of INH, we say, okay, great, that's adequate treatment. 9 months is better. But now the new philosophy is like, we have some new treatments out here and let's go with these shorter treatments because studies have been done on this INH 9-month treatment and very few people finish. It's very hard to get people to finish this course of treatment. So now we have some great new treatments. So if you are out there, if you're a school nurse or you see something that you are looking at that looks a little strange, it's because they have some new treatments. There's a treatment that we use that's very successful. It's INH and rifapentine. Rifapentine is in the family of rifampin, but it is different. It's 3 months and they take it once a week for 12 weeks. This is great. People like this treatment. The only drawback to this treatment is there's a lot of pills involved because the INH, the way it's packaged, the rifapentine is only 150 milligrams and they have to take 900 milligrams. But if they can tolerate once a week, it's great. If they can't do that, we got rifampin. They can take rifampin, 4 months of rifampin, or they could take INH and rifampin together for 3 months. So what is new in TB? We're kind of really excited about some new breakthroughs that have been coming out in TB. For years, there was nothing new in TB. We had the same drugs since the 60s. I think research has really stepped up and people are really getting invested in TB elimination as far as research and advocacy groups. So there is a new regimen that you might see out there for, this is drug-susceptible pulmonary tuberculosis. What I was talking about on the previous screen, this is just somebody that has latent TB infection. That means they had a positive PPD or a positive Igra, chest x-rays negative. They have no disease. The germ is now in them and dormant. We try to treat prophylactically. These new treatments are from somebody that actually has TB. I told you the minimum treatment for tuberculosis in patients is 6 months minimum. It could be 9 months if they don't convert in time. Well, this new treatment is a 4-month treatment. It's rifapentine, moxifloxacin, INH, and PZA. And then we have a new regimen, which it's really been going well. I told you last year we had 11 of these, what we call multi-drug resistant TB cases. Our multi-drug resistant TB cases can't take INH and rifampin. Our 4 best drugs are INH, rifampin, PZA, and EMB. We take out INH and rifampin, and prior to this new treatment, they'd be treated for 2 years. 6 months of that 2 years was with an injectable that they were injected with 5 days a week for 6 months. It was not pretty, and the side effects were not wonderful on all the drugs that they had to take for this multi-drug resistance. One of the medication, capreomycin, is what we used to use as an injectable. They don't even make anymore. Then bedaquiline came on the scene, and we replaced our injectables with bedaquiline, but it was still a 2-year treatment. Now we have bedaquiline, a new drug called predominant, and linezolid, and we're treating our multi-drug resistant TB in 6 months. The only drawback is the bedaquiline is $23,000 a bottle. So that is the barrier to that treatment. We're lucky at the state health department that we are able to sustain that. If someone needs those medications, we were able to purchase it. And they also have assistance programs if that becomes an issue through Johnson & Johnson. And that is all I got for you today. Anyone have any questions?
Thank you so much, Patty, for such a valuable presentation. We do have a few questions here. The first question is, can you please talk on housing solutions for case that might need it?
So if they're a TB case,
yes,
yeah, you can give us a contact, me or the health department, because we do have a grant that we have. I mean, it's a limited grant, so we can't have, depending on what's going on, we have to, do an application and evaluate. But if we can pay for their rent, if there's an existing place where they're living, we can pay for their rent or catch them up on rent. Or if they have no place to go, we could find a room or a hotel to put them in, temporarily until we can find them housing. The only thing we need is the vendor or the landlord or whoever is going to receive that check has to fill out a W-9 form, but we walk you through all that paperwork.
Great, thank you. Where can new immigrants get their IGRA tested?
So that's a really good question, and I meant to bring that up. There's a couple different categories of new immigrants. So the immigration people that come through our system with that are coming through, they're on a visa coming here and they get evaluated in their country, they would be coming to one of our sites or clinics. Now, if there's an immigrant that's going to a civil surgeon for change of status, that's something that's not covered by public health. That's something that's an out-of-pocket expense because they have to be evaluated for a lot of things to change their status. They would get referred to us only if there was something abnormal, like an abnormal chest x-ray. But the U for Ukraine now movement that's coming in. We did get funding from CDC to help address this issue. It wasn't supposed to be a public health response initially when the Ukrainian population was coming in, but it became one because they were calling health departments, and health departments were trying to satisfy this need. Some had more than others because there's enclaves of where the Ukrainians are being sponsored and locating. And so CDC identified that we would need some funding, and we came up with a plan. We work very closely with the refugee resettlement program and the state refugee program to help get the word out. Please get the word out too. And I think we're trying to update our website so they can get the information there. But for the Youth for Ukraine, they can contact any of our TB clinics, or TB the TB clinics or county. TB county health departments, and they should know where to refer. Most of the TB clinics are out of the health departments. There's a few that's not. They could also call our office and we can direct them, but they'll come to the specified location in their county. They will get a requisition form. They'll get a symptom assessment, a requisition form to go to any quest to get the Igra test results.
Okay, great, thank you. Do have another question here for you. With these regional sites like Lattimore, can we send people there for TB testing, IGRA, or will they only do TB chest x-ray? And is it free, or do they have to have insurance to go get services at these clinics? Lastly, where can children under 6 go? We were told that Lattimore will not see them, but maybe that is incorrect. Just a clarification.
Yeah, so it depends on it depends on what is the required service. Like the regional clinics definitely will see any cases, suspects, or contacts. They don't necessarily take anybody for, like I said, for LTBI. So they have to fall in those required public health services that are required, which are a suspect, a case, a contact, or a B immigration. Children that are entering school, usually if they get TB tested, it's mandated that they get a TB test to get into school. They are usually seen. I'm not sure about the children under 6 or why they were tested, or, it depends on why they're testing. Are they high risk? But usually they do take them. And, if you're not sure, or if there's a referral that someone's saying, they can't be referred there, please feel free to give me a call or reach out to me, and we can investigate what the options are or why they can't be seen in those particular clinics.
Okay, thank you. And then one last question. Can we get more detail regarding new 4 months TB treatment? Does the TB program provide rifapentine, moxifloxacin medication? What are adverse reactions? I'm looking for more information for patient education.
Okay, great. Yeah, we haven't, as no physician I know right now has used it in New Jersey. We do get the medication. That's all medications provided through the state. Our one barrier right now as to rolling it out is because it's a 4-month treatment. The recommendations that they just came out, they came out actually earlier this year, but they're on the CDC website, and I can be happy to share a resource with you. When I get done, I will put it in the chat. But the problem with that is the recommendation is that they need to have the fluoroquinolone sensitivity testing done, and there's no mechanism to do that right now. Our state lab is working on that, and the CDC is working on that. So some of the states like Florida and New York, they have these huge labs that can do it, so they're rolling it out. But once these little details get hammered out, you'll be seeing more of it, and the medication will be provided through the state health department.
Great, thank you so much, Patty.
Yeah, and if any physicians are going to start using this, they might want to consider a consult with the Global TB Institute if they're like private providers and not going to one of our clinics, which is 1-800-4TB-DOCS, and they can, get one of our expert TB physicians to consult with them.
Okay, great. Thank you so much. And I shared the handouts. I will share the handouts again in the chat for those who are interested and who may want the handouts for your own resources. But thank you again, Patty, for your wonderful presentation. If you do have additional questions, please share it in the chat box. Patty also shared her email as well. And so I am going to now, so you can stop sharing your slides, Patty. But before I turn it over to the panelist speakers, I would like to invite the president of the New Jersey Association of Public Health Nurse Administrators, Agatha Reedy, to say a few words.
Good morning, everybody. This is Agatha Reedy, and I am happy to be here today to do a welcome to our 16th annual nursing forum. And I also want to recognize Rutgers School of Public Health to always help us to put this forum together for the New Jersey public health nurses. In New Jersey, we are New Jersey strong. I can't thank everybody enough for all their hard work during the last several years in these unprecedented times, and for your contributions to continue to prevent, promote, and protect the public. I know that they've definitely been trying times, and during these times, our other programs also continued. So give yourself a round of applause. We have a great turnout for this forum, and I hope everyone finds something that you can take back, that you learned something today that you can share with everybody from your own place, as well as your colleagues throughout New Jersey. Let me just talk a little bit about NJAPHNA. We are 30 years strong. We just celebrated, we're really at 32. We just got together in May to celebrate our 30th year. It's really for the founders that really brought to the table in New Jersey that felt that nursing needed to have a say, and we want to continue that. Our organization is also recovering from the pandemic as well. We're trying new methods to get everybody to join us and share best practices, as well as different policies, procedures that we're all in it together. And if you are part of it, we have that ability to do that. So if you haven't thought about joining NJAPHNA, please think about it. For the last 2 years, we gave for Nurses Day. We've given unlimited nursing credits by working with a vendor to get them at a lower rate. So people have the opportunity, even during these times, to maintain their education of what was going on. And they have also changed what they're teaching. A lot of things are about public health. And of course, COVID-19 is one of the forefronts, the sexually transmitted disease. And we know that these things are all on the rise. And as of today, of course, since May, we know that monkeypox now became a public health concern by the WHO and then by the CDC. So, and we also know that we have to start learning how to live with COVID. We've put this presentation together with Rutgers, members of my team. So I hope you enjoy your day. And it's a real honor to serve this association. So if you are interested, please email me at areedy@virtua.org and I'll give you some facts. Currently, we are under discussion of membership for next year about a possible discount. The executive team is looking into that as well. Thank you so much.
Thank you, Agatha, for a wonderful welcome. So I'm going to take this time to welcome all of the panelist speakers to turn on their cameras. And I'm going to share a slide here. Okay, great. Thank you. So now I would like to introduce the roundtable speakers. The speakers will share their successes and challenges working in the clinics. First, we have for the Mega Clinic, Diddy Mae Jankakis. She is the Director of Public Health Nursing at Gloucester County Health Department. Then we have for the community adult-based clinics, we have Sammy Cameron from Passaic County Health Department. For our youth-based clinics, for 18 and younger, we have Scott Carter from the Ocean County Health Department. And for the infant-focused efforts, we have Kathy Jo Soden from Mercer County Division of Health. And lastly, for the home vaccination efforts, we have Agatha Reddy from Burlington County Health Department. Just as a reminder, before I begin, if you have any questions for a specific presenter, please put their name in front of the question, and then we'll address those questions at the very end. So I do have some questions here. I will start with Diddy Mae, and then I'll continue on. So Diddy Mae, what was the biggest challenge that you faced, at the mega clinics?
Good morning, everyone. Well, I mean, there were several challenges. So I might name a couple that were up there, and obviously to be expected with such a huge operation. But firstly, I mean, I just wanted to say that running a mega site 12 hours a day, 7 days a week, is just a crazy ask for someone to do. Everyone knows that when you work a 12-hour shift, by the time you drive there and drive home, your 12 hours turns into 13 or 14 hours. So you can just imagine the exhaustion of running a mega site. So I think our mega site, which actually is my success, was not run by a hospital system, but by the county health department. So I think we were very different, and that probably is going to be my success to talk about. However, I feel like staffing was a big issue for the mega site. We did use agency staffing through the State Department of Health for a brief period of time, but even that was a bit of a challenge. So we were trying to staff the site, and as we realized our space was small and we had to increase the space, we had to increase the staff. It wasn't the fact that we didn't have a lot of people who were interested in helping and working with us. It was trying to manage them and to make sure that we had enough coverage each day. So it was actually my director at the time who was kind of, in charge of getting the staffing together. However, this was very labor intensive for her. I mean, people were calling at all and texting her at all hours of the day and night. A lot of them would sign up and say they were available, and then their shift would come and then they wouldn't be available. Other people were saying, I signed up, but you didn't assign me to any shifts. How come I'm not getting shifts? So it was a little bit chaotic from that standpoint. However, a way that we did overcome that was to just know that X percentage of people were going to cancel each day and each shift and just overstaff each of the shifts. And then that kind of, we kind of got into a routine, and that really helped. So I would say that was a challenge, as well as documenting the vaccine, like through the state vaccine system. So we did have a backup system, which also had some challenges, but the state system is always a delay. Like even to this day, the bivalent boosters, I think, are just being able to be live today. So that poses a challenge for getting vaccines documented.
Great, thank you. Right, so for our next speaker, Sammy Cameron, same question, what was your biggest challenge?
Good morning, everyone, and thanks for having me on your panel. We had a lot of challenges, but the biggest one I would say was uploading our data elements into NJAPHNA using the HL7 interface. And I think that's probably what Didi was talking about as well. That was a huge challenge for all of us in the beginning of our vaccination clinics. We also had a challenge for our community clinic, especially with accessibility in terms of transportation for our residents getting to the clinic. We also, in creating an awareness of the clinic was another challenge. You know, when we first got started, we were just going, you know, trying to get the clinic open up, trying to get all our ducks in a row. So, you know, awareness was one of those challenges because we were doing something here, you know, we did, you know, how was this message being transmitted to the residents in the community? So that was an issue. We also had some minor issues clarifying who were eligible for vaccination in the various groups, because many residents, they were not sure when to come to the clinic. So you would find people showing up at the clinic, especially those who did not have access to a computer to register.
Great, thank you.
So, you know, and another final challenge we had is for those residents who did not have access to the computer, as well as not being literate, who could not even use a computer to get registered. So as we go along, you will understand how we solve those issues.
Okay. Were you guys able to create a place for them to, you know, register when needed at your facility?
Yes, we had. Actually, we collaborated with a company called Vault Medical Services, and we were able to do that registration through them, a certain part of the registration at least.
Okay, great, thank you. All right, Scott, I do have the same question. What was the biggest challenge that you faced at your location?
I think our biggest challenge from the Ocean County Health Department side was the term pediatrics. You know, we were pretty successful with our adult mass vaccination location, but they were adults. Now throw the word pediatric or underneath of 17-year-olds. Some of our staff just have never really dealt with pediatrics except for when they were in their school, in their clinical type of settings. Many of the staff that we hired over the COVID era were more of a retired nursing, older population where kids really made them a little bit uncomfortable. So what we chose to do was we sat with each of them, listened to their concerns, listened to their needs, tried to figure out how to overcome that piece. We identified some of our key staff that were comfortable with pediatrics. We were lucky enough to have 2 staff that worked in a pediatric ICU. And we kind of learned a little bit about growth and development, what we needed to focus with those individuals. We then actually reached out to one of our healthcare partners and brought in some of the clinical educators specific to pediatrics, where we put them through classes, we put them through some competencies. We just talked about how to interact with mom and dad and break that stress, because we know children feed off of mom and dad. We videotaped it, we sent it out to all of our staff just so that they had a comfort the first time that they kind of walked in. And then our other piece was, how did we deal with those that are on that autistic spectrum and those different types of spectrums, where you bring them into a large place or a place that's unknown, or even a doctor's office, how scary that is. And we kind of looked at our own space internally. So we chose just to do a pediatric only clinic where we could focus just on those kids from that age group of 12 to 17 during that time frame. And we chose to use our WIC location, which is one of the largest in the state, but it's kid friendly, it's color friendly, it's everything kid specific. So we kind of took them out of that sterile environment, put them into something that they saw that was kind of comfortable. And then we started looking at, how do we respond though to kids that may not do well from a shot, just getting sick, just from the stress and anxiety, and training our own staff to be able to interact And again, going back to those that never dealt with pediatrics for many, many type of years, I think those were our biggest challenges. And once the staff really started to say, hey, it really wasn't that bad, it became easier. And it became easier for the staff to say, let me take that younger kid. It was a couple weeks of challenge, but I think they realized that once they embraced it, and we had staff dressing up as superheroes, where we had the kids pick out their favorite superhero to give them the vaccine, really broke down those barriers to some of those challenges.
Well, that's really great. Thanks for sharing that. And I'm so happy that worked out and you guys were able to take a certain approach with helping to create that comfort in your environment as far as working with the younger children. Okay, Kathy, I do have that same question. What do you feel was the biggest challenge the infant focus efforts?
For having me. I'm humbled and honored to have been asked to be a panelist. And thanks, Scott. That was some great information with how you trained your staff for the pediatric population. For the infant population, I think the biggest challenge was, just as Scott had said, having vaccinators who were comfortable with the age group, because we keep lowering the number, and dealing with a 12-year-old or up is different than dealing with a 6-year-old, and certainly different than dealing with a 6-month-old. And so finding the vaccinators who were comfortable with that. Mercer County is fortunate that I'm a nurse practitioner and I'm used to dealing with all ages and have worked in pediatrics in the past. And I'm also an adjunct professor of nursing, so I'm also used to teaching nursing students how to vaccinate all age groups. Over the fear and anxiety regarding the 6-month to 5-year-old age group was the biggest hurdle. There was a lot of buildup to this being released and approved, and you heard this on the Vax Ops calls with just the same questions being asked over and over and over again in regards to more with emergency situations that may pop up with the release of a new vaccine. That was really only, I think, the biggest hurdle was just the fears, the anxieties, and making sure I had enough vaccinators to help.
Thank you so much for sharing. And lastly, for Agatha, what was your biggest challenge?
So great stories from everybody. It seems to surround by staffing. So mine really surrounds about going out to homes and finding the elderly unsafe. And there was a lot of times that I had to be involved in getting them to organizations or to get to their safety, especially if they didn't have any loved ones to even call upon, and it was neighbors. But sometimes we really found very deplorable conditions. And we then had another job to do, and it didn't happen all the time, but it happened more than a handful of times that we had to stop what we're doing, get other organizations involved, even getting the police departments in those areas involved, as well as my health officer, to make wellness checks until we really found out what was going on with those clients. So that was one of it. The other one I'm going to say is Burlington County is very big.
Mm-hmm.
And when you're sending out 2 nurses at a time, because we did, regarding that is one, strictly to be prepared for any emergent reaction that may have occurred with the emergency bag, was the travel and having visits situated so we could get more done in one day when we started the program. We always go out and we will serve homebound for flu each year, but the magnitude that came across our desks to serve people in their homes for COVID was a definite challenge. And lastly, if they had a history of any blood clotting, things like that, Ag got involved as well. Originally we started with J&J in the house, and then we also offered all boosters because J&J was not a fit for everybody.
Mm-hmm.
And not just boosters, the whole series.
Great. Such great feedback from each of you. I do have a question for Scott. are the trainings that you put together for the pediatric population available to share with others?
Allow me to ask the instructors first, if I may. They were not my employees. They were part of one of our healthcare associates. If so, it was saved as a YouTube channel. So let me see if I can get that answer by the end of today and add it to the link, if I may. But I will clearly ask for you.
Thanks, Scott. Thank you so much. Let's see. Okay, so I'm going to start with Denny May again. What are you most proud of, and perhaps your biggest success?
I guess I'm most proud of being the only county health department run mega site. So we were run strictly by county health department with our medical director. We did not have a partnership with a hospital. And we definitely came together as a whole, as a county. And we, definitely worked great together, and we had a lot of help from our other county departments. And we were able to provide, many, many vaccines, some days up to like close to 7,000 vaccines in a day. And the mega site itself, we gave over 435,000 doses. And since, it all began, we're now over 457,000 doses given. So I think that's our biggest accomplishment. We had great support from, county admin. My administrator was on site, just as much as I was. So it really is, I think, something to be proud of.
Oh, absolutely. That's really great, Denny May, especially to administer all those vaccines and actually having the support is awesome. Someone said kudos to Denny May and the Gloucester County Health Department, and thank you for all that you do. So that is amazing. For our next speaker, Sammy Cameron, what are you most proud of? And please share your success.
Okay, for our county, one of our proudest moments was when we were able to vaccinate almost 2,000 people on one given day.
Mm-hmm.
Not a big of our success, even though we collaborated with Vault Health. Vault Health brought in nurses because they collaborated with an agency. However, when the nurses arrived on site, I conducted a just-in-time training every single day for over 30 nurses, until things start dwindling down. I trained not only the nurses, but all the ancillary staff that were there on that site that particular day. And nurses came and go depending on, on their schedules. So that was great that we were able to do that and vaccinate so many people. And we also collaborated for this success with Vault Health Services, Vault Health Medical Services, and our Sheriff's Department, which played an integral part in organizing the transportation outside where people were supposed to park, the lines, setting them up to come into the center and things like that. And not forgetting Dr. Gungill and the health staff, the staff at this health department were present almost every single day at that site. So, and I just want to mention another proud moment for us is when we started our homebound vaccination clinics, because that was one of our challenges. We had issues where, especially those people who needed medical services, had medical needs, we had to go into their homes. They could not come out to us. So we started that very soon in the game. We split up the few nurses that we had extra, and we rode on the EMS rig, and we went, just as we got that call, we went out to those homes and serviced those in need.
Wow, that is.
Sorry, go ahead.
Oh, no, go ahead.
I just wanted to mention that we used our EMS for our homebounds initially as well. And that was a great success for us as well.
Just one last thing, in addition to that, we were able to acquire 2 medical mobile units, which we used in other areas in the county. So we had clinics there as well. And we were so proud to get those. We were grateful in acquiring those medical units that we were able to use to serve our community.
Wow, that is awesome. I mean, despite the challenges that, you all have faced, hearing these successes, it's great because, you're able to reach the community and give them the access to care that they need. So that's wonderful. Thank you, Sandy. So Scott, I have the same question for you. What would you say you're most proud of?
I think there's a lot of things that all of us are proud of on here. And when you listen to the health departments going through the same stressors, success is managed in so many different ways. Our county, we're about 650,000 in terms of residents. A good percentage is the older population. So when we look at that, it's just overall of how do you get the individual to the site that needed to go, and how do you do it safely? And along with not only that is managing the COVID testing sites, managing the homebound, managing all the other illnesses and common disease and contact tracing that had to happen all during the same time, which is truly a challenge. And I think some of the successes is being able to just identify that you hear rumors of something new's happening, try to put it together ahead of time, and then be told on Friday at 4 o'clock, this is what's happening Saturday morning, and roll it out. I think those are the successes of pulling the teams together and just having that open conversation and managing. And, I know the topic for me is really youth-based, but, we were our own mega site in Ocean County, not New Jersey, identified. And I think the most proud is that we're at 160,000 vaccines just through our agency alone, without that designation, pulling it all together. And that's what I think is successful, is that when those people that walk out of our site or any site say, I got my shot, and the relief is there, that's the success.
That's great. That's great. Thank you so much for sharing that, Scott. So Kathy, I have the same question for you. What would you say your biggest success?
Sure. Our first clinic came together really quickly. Once we got the green light from the state that the ACIP had approved the PWE doses, we had already gotten our standing orders signed, and as all the counties were a little trying to gear up and prepare for this, as I said, there's still a lot of fear and anxiety regarding it. We were lightly advertised for 48 hours to put together a small clinic designated just for the 6 months to 5-year age group. And I was so blessed to have an MRC volunteer come forward who is a pediatric ER physician, relieved my anxiety of not being the only person on site to know how to respond to a pediatric emergency. And that was always our greatest fear, what's going to happen. It was a small clinic. I was one of 3 vaccinators. The third MRC volunteer, my second MRC volunteer, my third vaccinator, had not vaccinated this population before. So we did a just-in-time training for her, where she watched a few and I held her hand through a few until she was up and running. And now she's one of my rock star vaccinators for this age group. But that clinic, with just 48 hours of advertising, we had a showing of 54 vaccinations. So for my follow-up clinic, which is the one I'm really proud of, we widely advertised. I was able to partner with 4 of my local health departments from Lawrence, Montgomery Township, Hopewell, and Princeton. I was also able to have partnerships with 3 local organizations, our Mercer County WIC, Children's Home Society of New Jersey, and Homefront. They all tabled and also gave giveaways. There was about 6 different tables of giveaways for these families and these children. And we were able to give out 121 vaccinations that day. And I think between those 2 efforts, getting the word out to all the locals helped relieve their anxiety that we did not have any adverse events on site related to the population. And since then, they've all been kind of doing their own thing and holding their own clinics without any reported events that I'm aware of.
Wow, thank you so much, Kathy. That is amazing. Just to have that, again, having that support and, those that are there to help with, getting that push and helping those in the community that really need the help. So wonderful. And lastly, Agatha, can you please share your biggest success?
Well, it's really phenomenal because people already have said it, but it really was developing a homebound program very quickly and getting out in the community for people that really needed our service. I fielded many calls, went out myself initially as well, so we could get caught up on the long list that we had coming in. And we were able to do 10 visits a day. But I have to tell you, just this one gentleman that called me who was a quadriplegic, and he was getting ready to go into Pennsylvania to get his first shot. And I told him to hold on. And he lived alone. He had no family. He had some caregivers, but just the transportation alone was going to cost him over $1,000. So getting to that man and everybody else that needed our service was a great accomplishment. And, you know, doing 10 visits a day, we did a 15-minute wait in the homes as well. We did not leave. We made sure that everybody was fine. If they had a known anaphylaxis reaction, we had to stay 30. That didn't happen too often, but we wanted to make sure that they were safe and that there was no reaction. And of course, you know, the education that we were able to provide during that time, in case something happened after we left. So, but it's amazing from all the panelists of you sharing all your experiences. I know that everybody is having a great takeaway.
Thank you. Thank you all for sharing again, as I said before, even though there was those challenges, there are some successes there, and you all are doing a wonderful job, especially reaching the community, and, you know, showing them how much you all care. So kudos to all of you. I do have a question here. Did anyone have problems getting undocumented people to participate in getting immunized for COVID-19? If so, how did you encourage them to come out with fear from ICE?
Well, it's City May, so we really didn't have a huge issue. I mean, I think what helped us was down here in the southern region, we have a lot of farms, and we actually were going out to the farm. So we were sending, you know, a group of vaccinators out to the farm to do like pop-up clinics. With that being said, I mean, we did get, you know, some people who gave us some misinformation. You know, like for instance, you know, we might have gone out to the farm with the J&J because in the beginning it was a 1 dose and done kind of thing. And, you know, even though we advertised that it would be for people 18 and up, people under 18 would, you know, come and get it. But other than that, I mean, you know, that did help us going to the farms, you know, to be able to vaccinate individuals. That did help.
And this is Sandy. And what we did too, we make it very clear that our clinics are open for anyone. And we made sure that message was spread wide and far. So we did not have issues with them coming to our site or where we were.
Great, thank you.
And I'd have to ditto what Sandy said. We didn't either because or it was open for everybody. You know, the goal was to get as many people in the public vaccinated who wanted it.
Mm-hmm. Great, thank you. And you mentioned some misinformation while going out to that area. How were you able to address that?
Well, I mean, sometimes, you know, some of them did kind of slip through, but, you know, it's just trying to provide education of who was able to be vaccinated. Right. But I mean, it really wasn't that big of an issue, but it was just like a few, you know, like maybe a handful.
And another thing we did too on our flyers, we made sure we made that very clear on our flyers. In addition to, you know, a vaccine is available for anyone. Insurance was not required. So that, that was a way of getting anyone into the clinic as well.
Right, having that message is extremely important, especially for those who don't have insurance. So, okay, so my next question, again, Denise, I'll start with you again. What would you do differently in hindsight?
I'm not sure that we would do anything differently. I think maybe pick a different space, one that, although it's hard because, with a lot of people waiting in line, you need to have space for them to wait in line. However, it wasn't convenient until we opened up the second building. But really, in actuality, I feel like I would hope the biggest thing I would like to see is not having quote unquote mega sites be asked to be open 7 days a week, 12 hours a day. Maybe somehow like rotate that, maybe be open 12 hours a day, but rotate like this mega site's open these days and this mega site's open that days, and have more sites available. I mean, I understand there were a lot of people, we were trying to get vaccinated. But I just feel like it was a lot, doing the 12 hours, 7 days a week. So I would like to see a change there. But that was not under our control at the time.
Thank you so much for your feedback. Sandy, my question to you is the same thing.
For us as a county, not having an electronic medical record system or a scheduling system in place was an issue for us. Because if we had that in place, we would have been able to have a quick jump start with registering patients for our clinics. However, we are currently working on putting those systems in place. And we will also continue to recruit and train our MRC volunteers for emergencies, because I have it highlighted here, but I didn't mention it when we talked about our biggest success. One, what made our success even, what it was, is the support of all our medical reserve corps volunteers. They were supportive, they were there every day, and they did all the behind the scenes work in terms of packing all the supplies for the nurses that are coming in every day, checking supplies at the end of the day, and getting things just ready for a jump start at 9 a.m. every morning. So, we will continue to train our MRC volunteers, because as everyone is aware, they go and come, we get new ones, the old ones, so the training has to be ongoing.
Thank you, Sandy. Hey, Scott, what would you do differently?
I think the biggest piece, if I could look back, is figure out a different messaging system. Trying to find a way to break down that noise of the media, the misinformation, the social media rumors, and just try to present some of the facts that were there. Not to convince people or talk people into doing it like a salesperson, but to just be able to say that this is the information that's known and trustworthy. Trying to get our health educators out to the community was challenging because everything was shut down. We couldn't get that one-on-one conversations where we could go to the women's clubs and the men's clubs. So a lot of it was reliable on social media, and that was, I think that was a challenge. You try to do the best that you can, but you can only get so much messaging out so quick, and no matter how quick you get it out, you're already behind with some of the mixed messaging. That's a challenge. And then that bigger piece of that larger senior population, as we said, who can't focus on everything being web-based. Go make an appointment. How do you get that information to them? You can only create so many flyers and so many brochures, but how do you get it out to house? So I really would love to go back to somewhere of a communication theme if I could refocus for the next time.
Yeah, thank you so much. I definitely agree with the misinformation and social media that created a huge barrier during that time. And, you know, communication is definitely important and how we deliver that message. So I agree with you, Scott. So thank you for your feedback. Kathy, what would you do differently in hindsight?
Things we've already done different. After the second larger clinic, we had invited those 3 community organizations because they are in the heart of our vulnerable populations in Mercer County, especially Children's Home Society. They reach out to the Latina population and have a fabulous maternal child health program. So we were hoping that by partnering with them and having them advertise in their respective communities, that it would garner more interest of those vulnerable populations to get the 6 months to 5-year-olds vaccinated. And that did not prove to be very fruitful. Most of the patients or the parents and families that were presenting were not from those vulnerable communities that we were really looking to focus on. So one, we've moved into a little bigger vaccination space because we were planning on the kids, but then you have a parent, you have 2 parents, you have 2 parents and a grandparent. So we needed more space for everybody to hang out for that 15 to 20-minute observation period. And we are little by little going into each of those individual organizations in the vulnerable population and holding mini pop-up clinics in their offices where those populations visit more frequently and are more comfortable.
Great. Thank you. Thank you, Kathy. And lastly, Agatha.
You know, when I look back at this, I think I would have gotten our MRC involved sooner than we did, to then also go out with one of our team members, which we did eventually pair that off after like the first month. I think our efforts could have gotten to people sooner than originally had planned. But I knew I needed, the MRC was also supporting our other area, community-based clinics, etc., as well as the mega site for Burlington. So it was a little challenging. But once we did get them involved, especially some with a home care background, who were very comfortable going into homes, and it really did support us even better than in the previous month. But that's what when I really looked at that, I would have done that.
Okay, great. Thank you so much, Agatha. So I'm going to go to the final question. Diddy May, do you have one approach to vaccine hesitant that you found successful?
Well, I mean, I find it challenging. I don't think one approach works kind of for everyone. However, we have had success with, you know, just kind of letting parents know, like, this is what your child is due for, and this is what your child's going to get at this time. And then, you know, if they have specific concerns, you know, address them. But that seems to have had, you know, a decent amount of success in our clinic.
Great, thank you. Sandy, what are your feedbacks in regards to that? What is your one approach to vaccine hesitant that you found successful?
What we found successful when dealing with vaccine hesitancy, we're conducting educational programs at all levels in our county, from residents to elected officials, as well as the stakeholders serving in our healthcare facilities, in all our healthcare facilities, I should say. And these include pediatricians, school nurses, teachers, community-based organizations, and such like. We also conducted what's called boots on the ground, even though you know, everybody was concerned about COVID, and we were concerned more about those residents who could not get access to let's say television or you know, information otherwise. So we stood on the streets many days and we just handed out flyers in different languages, things like that. We also had at every vaccination clinic, we had a panel of health educators available to dispel any myths and provide clarity regarding these vaccines. We also provided educational materials. They were available at every vax clinic. And we updated those on a regular basis because, as everybody knows, information was coming all the time. And we had to keep changing our information and keep updating as the guidance become, as we got those guidance from NJDOH and from the CDC. We also educated our staff within who were answering telephones, in addition to all our contact tracers that were working directly with us at that time. So as we got the information was transcended to everybody within the clinic, and all those helping with that were stationed at the health departments.
Great, thank you so much, Sandy. Scott, what is your feedback in regards to vaccine hesitancy? What did you that you found successful?
So it depends on how you measure successful. Ocean County is probably the still lowest vaccinated county in the state of New Jersey. We struggled to get over 70% at one point, where we were part of the 6th task force that came together, focusing town by town. We have a large religious population that doesn't have a belief in vaccinations within our county, and that was a challenge. We have another large religious type of population that just thinks that the government's giving them bad stuff, and that's the challenges that we did. So we brought all of those key leaders together, and we met weekly, week after week, trying to figure out how to break down the stigma, how to break down that status. How do we find those key leaders just to go in and have conversation? But I think the biggest factor when we talk about the youth piece is because mom and dad's not vaccinated, I'm not seeing the kids being vaccinated. So it's just that perpetual challenge that we have here. We're still getting a couple first dosers still walking in the door from 2020 now. But it's the mechanism of this county, I think, and the makeup of this county and what they believe. That's the challenge for hesitancy with us.
Yeah, Scott, I do agree. I've worked in the vaccine world for about 5 years, and so I do understand there are a lot of vaccine hesitant, especially with me working with parents, vaccine hesitant parents. And I think, it's providing that education and also sharing stories, just to kind of build that trust with parents, some of my experiences. And so, like you said, if the parent don't believe in the vaccine, of course, the kids are not going to get vaccinated. Or if they get vaccinated for their first dose, they may not come back for the follow-up. So I agree with you and understand where you're coming from completely.
And some of the other issue on the younger side, and maybe so, Kathy, Joe, you see the same thing, is physicians don't want to have COVID in their offices because of the difficulty of managing COVID and going through the processes with the state of New Jersey, that it's easy to get it in a doctor's office where once they walk out, they're like, I'm not going there. I think that's the other challenge that we have for the younger kids.
Yes, thanks, Scott. So yes, as we can move on to Kathy. Kathy, what are your thoughts?
Yeah, exactly. Yeah, I wish they would turn all this over to single dose vials to make it easier for all primary care doctors to hold the COVID vaccines in their offices, but maybe that's coming down the pike. But for now, it is what it is, and we're dealing with it. At our first clinic, we took a census afterwards of those that presented for the vaccine to see what municipalities they were coming from. Need to twist the arms of some of my local health department nurses to come and support me at the next clinic, since I was vaccinating many of their residents because the pediatricians did not have the COVID vaccine stocked in their office. One of the largest pediatric practices in one of the municipalities was only stocking Pfizer, and a majority of their parents wanted Moderna, and that's who I was seeing at my clinic also. And what I found is that if you're presenting to a clinic, you're already convinced that you're getting this vaccine, you're already invested in it. And what surprised me is I've had a few parents that show up just to seek information about it, to have factual information given to them and the nitty-gritty details and breakdown of Moderna versus Pfizer for their young one. But again, their foot's already in the door. They're already in front of me for a vaccine. And it was just a matter of them deciding which one did they want to go with, the Moderna or the Pfizer. So there, I think, like you've already said, if you're not convinced you need a COVID vaccine or you're anti-vaccine, I'm not going to see you. And our numbers are already declining each week that I'm doing the PWE clinics. They're getting less and less because those that really wanted it were first in line and they were at that first or second clinic. They finished their series for their child and they're done. And my overall numbers have declined. I just did a clinic last night. I was there for 4 hours and we only vaccinated 39 people.
Wow. Such a big drop.
Mm-hmm.
Yeah. Okay, Agatha?
So let me just talk about first the, just for the homebound clients. So if I was called after the screening process occurred, if there was some hesitancy, they would let me know. And I would give a call because although they might have wanted it, they had some questions. So the key thing was education, and you provided the education. What you did find out was a lot of physicians were non-committal. You know, they were really leaving it to their patients, even though their patients might have been calling them to say, should I get this? Some absolutely said yes, some did not. I remember just also having a conference with a few, but because they wanted their loved ones also on the call in regards to should grandma get this vaccine? And I think that also assisted with that hesitancy. As a county, you know, my director is a physician. He went to a lot of town halls to talk to people that were hesitant, especially in our areas that there wasn't a good uptake in the vaccine, as like Scott was saying. Well, we had pockets that we didn't have really good turnout, even though we did several clinics. But education was the key. And you know, Kathy, you're absolutely right. Our numbers are dropping with the PWE clinics, and they did come out early to do it. I think a lot of parents are hesitant because it's such a new vaccine. It's an EUA. It hasn't been tried and true. And even that's what we had initially, even with the adult population. And it certainly was not a cure for COVID. Hopefully, if people did develop COVID, they had milder symptoms. But it certainly helped during the process where treatment then became available for really the sick individuals that were hospitalized, etc. And we know now that less people are dying because of the vaccine and they're not getting as sick. So that's a positive. We're learning during this process. I think it's, you know, first in our era that we've even been faced with a pandemic. I mean, the last pandemic was was 1912. So there's just still a lot to learn with COVID. And each day, you know, I think the issue with the media, it changed. And now we were selling something new the next day as soon as new evidence came out. So as healthcare providers and as nursing professionals, we were at task as well. And we tried to give the clear facts at that time. So we did our best, and I think we really came out of it very well. I think we did meet those groups, and I think people who did not want it won't get it until they decide that they want it, or their children.
I just want to add a little bit on that. And, you know, what I'm seeing actually now is that parents decided to wait this thing out. Last week, I believe I had 2 or 3 first doses, which I thought was really good. So parents, I think they will come around eventually.
Yeah.
But I think they just wanted to, you know, wait it out a little bit to see what, you know, what's going to happen.
Agreed.
Yes, and yeah, I do agree with that. I often heard a lot of people mention waiting to see and waiting. And so if they're waiting, they're going to make their kids wait as well. And so, you know, again, I think I think you all are doing a wonderful job, and thank you for all that you do. Because, you know, with all of the administering of vaccine that you've done during this time, we still have that big population of people that got vaccinated, which is great. So thank you. And so we do have a question here. Did the local health departments in your counties run COVID clinics? How were the locals supported?
I can say a little bit for the other local health departments because we are a county. I know Passaic City had a few clinics, and Patterson City, they had clinics as well. Wayne Health Department, many of the links agencies within our county had clinic, even though they might not have started, you know, at the earlier times, but they did eventually, and they still have clinics for us here at the county. We are a monkeypox hub right now, and we have daily vaccination clinics from 12 to 4 every day, Monday through Friday, and it's ongoing here.
Thank you, Sandy. Does anybody else have any response to this question?
So from Ocean County, if I may, we started in 2020 of March, where we created a COVID clinic at our Ocean County College site and created it as a drive-through. We are the only health department within the county, other than a small town on Long Beach Island that has their own health department. So we managed the county-based COVID clinic, not only for residents, but then we created our own first responder COVID response thing, so we can keep those guys in the job where they didn't have to sit in lines for hours and hours. We had separate times, separate location for them to come in and to test, and even so doing the same thing now for the vaccinations, that the first responders get the priority for us to keep them doing the job that they need to do.
Great, thank you. Anyone else?
In Mercer County, we're a little different because we're not a department of health. We are a division of health. So we are not full staffed with all the individual departments that you would find in a typical health department. So the locals are really where all the action takes place. I'm relatively new to the county, so I'm not sure what kind of support my predecessor gave to the locals, but that's certainly how I see my role here in the county, is coming up alongside and supporting all the local nurses in their efforts. And I have joined some of them with their own vaccination clinics, because everybody's short-staffed and needs the extra hands. And if I'm available, I go. But that's really, and I try to disseminate as much information that comes across my desk. I push it right out to them if it's applicable to what's currently going on.
That's great, thank you.
And Kendra, I just wanted to add a little bit that I just remembered, actually, when, you know, everybody's giving their little piece regarding vaccine hesitancy. What I found actually worked a lot is when, well, we conducted several vaccination clinics in the business community. We went to where the people were.
Yes.
And what I found was that if one coworker got the vaccine and the other one was on the fence, he would be, you know, that his friend getting the vaccine or her friend getting the vaccine, you know, made him get the vaccine. So we had a lot of those, especially in the business community, because, you know, we were there in place. People are coming, people are talking, people are outside waiting to come in, but they're watching to see what their friend is going to do or their coworker is going to do. So we found that, you know, that really worked. And, you know, whenever we went out to these businesses, we, you know, we had health education there to answer those questions. So I thought that was one interesting piece.
That's great, Sandy. And I have experienced that. Again, like I mentioned, I've worked in the vaccine world for 5 years. And when you share that you've gotten vaccinated or you've gotten your kid vaccinated, and they notice that, well, nothing went wrong with them, right? Right. It kind of encourages, you know, that family member or friend to go out and get vaccinated. And again, going back to what I said before, you know, sometimes the storytelling, you know, helps, especially with providers. If a provider said, well, I've gotten my child vaccinated for, you know, COVID-19 or, you know, or another type of childhood vaccine, the patient is more likely, they put that trust into the provider or that friend and they're more likely to go out and get vaccinated. So it's just, you know, not only to help the education or the communication, but it's also that trust that is there. So that's a pretty interesting story, and it's something that I've seen in the past working in the vaccine world as well.
Yes, and you see that yellow button that came out from, I think it's NJDOH, the yellow button that says I got my shot.
Mhm.
That was a big hit too for people who didn't want to get the vaccine. They wanted to wear that button to show everybody, oh, they got the shot.
Nice.
So that was a huge, we used that to the fullest.
And Stan, I want to add one thing. These are great stories, but I also think when we went out to some of the the businesses, just their boss or their president, you know, got the shot first from us. I think that also helped.
Yes.
We did a site in Burlington County. I don't know if everybody knows that we have a site for Junior's Cheesecake, which is, you know, nationally known. And the owner came down that day that we were doing it. And the response was really great with that. He just felt that he needed to be there that day. And that's that he cared about people and etc. In fact, he gave every one of our nurses cheesecake, whether they were there or not, if they were back in the, he sent home a Junior's Cheesecake, but he was there talking to his staff and making sure that they were protected. So I think when you see that, I think that sends a lot. It's just like us witnessing the president or presidents, because we had two, get their vaccine. I think it was a really good message, so to speak.
Thanks, Agatha. Who wouldn't want Junior Cheesecake? I mean, so thank you so much.
That was very generous of them. I think, you know, and, you know, for the most part, a lot of people gave back to the healthcare professionals during this time, and no matter what they did, at all levels. And that was really nice to see.
Absolutely. I do agree. You guys work so hard, and you do so much for the community. And, you know, whether it's raising awareness to make sure that we're all healthy and going above and beyond. So, you know, I thank you all for all of your hard work and your feedback that you provided today. I'm sure that all that is on the webinar today can take some of the information that you provided and benefit from this information. So thank you for sharing your successes, your challenges, and just to kind of, you know, wrap this up a little bit. Is there anything else you would like to share that we haven't discussed? Any additional lessons learned?
One thing I can say is that in public health, we have to always be ready to move. We have to always continue doing our drills and just be in the readiness state of mind. We never know when something is going to occur and how. So, you know, keeping up with our training and our drills, you know, I think, you know, will benefit us in the future.
I agree. Thank you. Thank you. Thank you so much. Sandy, thank you. Diddy May, thank you, Scott and Kathy and Agatha for such great feedback. And as Colleen mentioned, and thank you to also the local health and private health sectors for all you have done. This was really great. And again, thank you for your wonderful information. So at this time, I think I have one more thing here. Public health officials at the state level should include the hands-on people such as our panel for any future challenges. So that was mentioned there. So yes, so at this time, we're going to take a 5-minute break before we bring on our next speaker. So yes, please take a 5-minute break and we'll be back on at 11:35. Thank you all.
Bye.
us in the, here we go. Thank you. So I want to talk about how, again, happiness is a precursor for our own success. Today, I'm going to review how you can achieve, sustain, and cultivate positive emotions, which not only leads to healthy lifestyles and behaviors. Cultivating positivity builds up our own defense mechanisms when we are faced with difficulties in life. So let's begin this session with just a brief meditation. We had a wonderful morning hearing from our panelists, and I just want everyone to take just a few minutes to see how easy it is just to relax. Let's just sit comfortably in our chair right now. You know, as you do, as a lot of our nurses, when you take someone's blood pressure, you make sure their feet are on the floor, they're sitting back, they're not crossed, their legs are not crossed, their arms are not crossed. So let's just sit nice and comfortably in our chair. And if you would, just close your eyes and get ready to bring attention to your breath. I want to share with you a guided meditation called Smile and Be Happy. So either gently close your eyes or maintain a soft focus, gazing about right by your feet. And take a slow, deep breath in to give yourself presence in the moment. Pull in for the breath in the count of 6, 3, 5, 6. Hold for 4. And exhale for 6. Let's do that again. Pull in for 6, 2, 5, 6. Hold for 4. And exhale for 6. And just take a minute to gently scan your body mentally to see if you have any tension anywhere while you're breathing in for 6, holding for 4, and exhaling for 6. One more time. Breathe in, hold, and exhale. Okay, and welcome back. And I really would like to know if any of you could just put a little quick note in the chat. How many of you actually here today do practice some sort of guided meditation or mindfulness, either with yourselves or you do that with the patients that you work with? When someone presents very anxious or nervous or apprehensive, do you ever take just a few minutes just to have them breathe with you, just to get them centered? Okay. As healthcare practitioners, a large part of our profession is to provide biopsychosocial education during our encounters with our patients. So our best practice suggests that we try these relaxation techniques on ourselves prior to guiding one of our patients through this process. This helps empower us to be more at ease during this very poignant exercise. Another question I want to ask, how does everyone feel today? It's such a common question we ask, and unfortunately, we don't always answer honestly most of the time. For some of us, our days are fine. We have great days, and for others, we're just trying to survive. I chose to talk today about how we can achieve, sustain, and cultivate positive emotions in our lives. Research has proven that even if we try to focus on a positive experience in our life, these negative memories remain more prominent than our positive experiences. So just take a moment and reflect back on a day you recently had, when in the overall picture of your day, it was an okay day, but yet there was one issue that might have stood out beyond them all. Maybe you were driving or commuting or traveling and someone cut you off, or you nearly almost had an accident, or someone looked at you wrong, or someone bumped you, or you reside in an area where there's it's uneasy living, it's not comfortable. That issue may have monopolized just a small fragment of that 24-hour day that we were in, but the impact of that negative emotion sticks with us for such a long period of time. Psychology research has determined that. And this is what happens in our brain. This negative experience has such a strong impact, it just remains more prominent. It remains in the forefront of our mind longer than a positive one. So today I want to talk about how we should practice focusing on the positives while suppressing the negatives. How are we going to do that? Well, it's a part of us as being a healthcare practitioner in our training. We're taught to focus all of our assessments when we're working with patients to expand beyond medical complaints, right? Towards extracting the individual strengths and coping mechanisms, their survival skills, their behaviors, their thoughts and actions, all to promote resilience. So even though this is the focus that we have on our patients, it's really time now to take that same advice and practice it on ourselves. So I want to invite everyone for a polling question right now in the chat. Just think about for a moment, what are you searching for in life? And just type your name in the chat. What is really the biggest thing that you want out of life? Just take a few moments to pop it in. And let's look at all the responses, what people are saying. Okay. And most of us really want to obtain happiness. Joy and happiness are fundamental human emotions, and happiness ranks high in our personal and professional world. Just recall all these historic words, like, for example, at the Declaration of Independence, we have embedded in there the pursuit of happiness. And since 2002, the World Health Happiness Report has been initiated and established, and it's using statistical analysis to determine the world's happiest countries. So I want to ask you a question now about this historical pursuit of happiness and this current pursuit of happiness. If this is still going on, why haven't we mastered it? What's missing from our lives here in 2022 that we are still on this lifelong quest for happiness? So I want to share with you some current research from Dr. Robert Lustig. He's an American pediatric endocrinologist. He studies at the Division of Pediatrics and Endocrinology at the University of California, and he specializes in neuroendocrinology and childhood obesity. He chooses to explore this phenomenon about happiness and pleasure. And this is fascinating research, and I really feel that this will deliver what we're searching for today within ourselves. So we can all agree that we are searching for positive emotions in our life. And what I'm here to talk to you about today are just two distinct positive emotions that typically and have been intentionally conflated. They've been combined, but not for the reasons of attaining happiness, but for the reasons actually to maintain addictive behaviors. These two very poignant and often conflated emotions are pleasure and happiness. Now, pleasure is an emotion that we experience when something feels good, right? It's exciting, it's stimulating, it promotes our neurons to release dopamine. But yet, pleasure begets pleasure. As we pursue the pleasure that we previously had, that previous euphoria, we find out that we require a stronger means to increase that rate of pleasure in order to achieve the previous level that we had. So when I'm talking about pleasure and the need to increase our tolerance to get more, I want you to keep in the back of your mind, what does that sound like? Right? What does that sound like? In our healthcare, we always think triggers addiction, tolerance. So the long-term effects of chasing pleasure can evolve into addiction. Substances, controlled or prescribed, we have pleasure from food, behavior, sex, shopping, what else? What other pleasurable addictive behaviors, can you think of that you might be engaging in or have engaged in or know people that engage in? It monopolizes their thought process. These pleasurable behaviors and pleasurable substances are all around us. So what are we to do? So today I want to separate pleasure and happiness and not have them remain conflated, because if we understand the pleasure-seeking behaviors will not result in attaining happiness, we then will be able and be better equipped to distinguish them between the two and then pursue what we need to be happy. So not to conflate pleasure with happiness. That's the first step that we have to do. So there's opposing principles between pleasure and happiness. And I just want to go through the 7 that Dr. Lustig had in his research. The first one is that pleasure is short-lived. Now, when you think about pleasurable experiences that you've had, like, for example, amusement parks, roller coaster rides, excitement in the moment, shopping, drinking, anything else that might give you a rush of pleasure. Now, that same rush that you just experienced, for example, on the roller coaster, how do you recapture that high again? How do you recapture that pleasurable experience? Well, you have to go on it again and again, or even go on a more exciting roller coaster, one for a longer duration or a more daring one, which causes, your body to build up a tolerance at each level. You have to then pursue more and more. So what does that sound like to you? What kind of ailment or disorder, disease does that sound like to you? Just hold that thought. On the opposing side, happiness is not short-lived, it's long-term. Happiness is a state of well-being. It's something that is built up over time and it resonates off of individuals. You never lose the state that you are in happiness. It remains with you. And once you experience the state of happiness, it's possible to return to that same state through the same experience. You don't have to increase anything. The second difference is that pleasure is visceral. Pleasure is something that is experienced physically, like through an action through the body or some sort of achievement. And that's the reason that pleasure begets more pleasure. To first achieve the first high of pleasure, you need to attain the same and greater momentum as the last. It's a lived and lived experience, like sex, shopping, substances, activities. Your physical body and mind are interacting with something. It's visceral. Happiness, though, is ethereal. Think about it. It's an out-of-body sensation. If it actually were tactile, we would be able to purchase it or hold it or make it. And that's why centuries later, people still remain on this quest for happiness. It's another level of cognitive ability. It's something that you must train yourself to do. They may pursue it in advertising, Coke is happiness, Happy Meals, but it's not anything you can touch. Happiness is something that is out of body. Third, I want to talk about pleasure is taking. So think about it. When you want to achieve pleasure, you're taking something. You're putting it in your body, on your body, or around you. It's something that you have gotten and have in your possession. But yet happiness comes through giving. There's a saying that there's gift is in the giving, right? And as you might have heard, joy is the one feels in giving rather than receiving. That is where these sayings come from. Giving and happiness are tied together. And to achieve happiness, you must start giving. The fourth of pleasure is it is achieved through substances. Going back to being visceral, going back to taking, it's something that you must do now, and it's something you must take to experience pleasure. And addiction is grounded in pleasure-seeking behaviors. The repeated act of requiring increasingly the same rate of pleasure does result in addiction. But yet happiness is not achieved through substances. Think of an individual, someone who's sober, someone who's existing on the bare minimums that life can offer, having their basic needs met, and they may report they're the happiest people on earth. Reflect back on yourselves if there was a time when you were destitute without things, but yet through companionship, through giving, through just being connected with someone might have brought you more happiness than you could ever expect. So happiness does not require substances. It is not something physical or tactile. It is an ethereal state of being. The fifth one is pleasure is experienced alone. Think about it. You can eat alone, right? You can get pleasure from food. You can get high alone. You don't need people around you to get any pleasure when you're seeking. It's an external satisfaction. It doesn't require people or even community at times. But yet for happiness, as I mentioned earlier, it's connection. You're happier when you connect with people or living beings. And I'm going to go into a little bit more about that when I talk about different things we can do to increase our own happiness. And Dr. Lustig has something about the 4 C's. So I'll go through that. So the 6th differentiation is that in pleasure, they have extremes and they do lead to addiction, because the pursuit of pleasurable behavior over and over again is to experience that previous emotion, right? But with happiness, one can never get addicted to it. Your body doesn't crave it, right? It's not something that you would destroy relationships over to achieve. It's not biological or neurological or psychologically addictive. There's no means to it that way. It's just a state of being that people want to achieve, but it's not something that's going to be addictive to one. So there's another difference. And the last most profound piece is that seeking pleasure neurologically creates dopamine in our bodies, because dopamine is a pleasure-seeking neuron. It's a part of the brain reward and pleasure centers. This initiates action and it motivates us to work hard to achieve the same or similar satisfaction for reaching the goal. And it has positive attributes, dopamine does, but it also has a lot of negative attributes. And when dopamine is overstimulated and mass produced over and over, it kills off the neurons, thus leaving your body in a state of addiction, of craving to get that same response. But neurologically, there's nothing you can do to get through it, because the more dopamine you produce, the more dopamine you lose. And to get more, you have to create more over and over, thus that addictive state of being. But yet, scientists have found that happiness releases serotonin. And serotonin has long-term effects. Individuals with elevated levels of serotonin are peaceful, they're calm by nature, they're open, clear-minded, and are socially dominant. When you have a deficiency in serotonin, it actually, research has found, it makes people anxious, makes them depressed or aggressive, lower self-esteem, and that results in a lower mood. And also with serotonin, the more you produce, the more you retain. It doesn't get eliminated like dopamine. In serotonin, you build up your own reserve. But interestingly enough, the one thing that can destroy serotonin is dopamine. So ironically, what this means is if you're striving to achieve more happiness and you work so hard to build up your serotonin levels, like through mindful, holistic practices, research is uncovering that while you are partaking in pleasure-seeking, dopamine-driven behaviors, simultaneously as you are pursuing your increase in serotonin through mindful practices, these dopamine neurons are destroying all the serotonin that you have now created. So in the end, our pursuits of happiness historically continue on because people keep conflating happiness and pleasure. And the more pleasure-seeking behaviors we seek out, the more we're killing off our serotonin and our happiness. We're destroying our reserve. So this big takeaway I want to share with everyone today is the more pleasure-seeking or dopamine-driven behaviors you participate in, you're destroying your serotonin practices that you're implementing, thus maintaining this pursuit of happiness cycle. And I really love this research because awareness is key. Just being aware of what chemically happens to our bodies during our actions is really what I think is going to best assist us today. Now, how are we going to build up our serotonin? How are we going to increase that defense so we can get that ethereal happiness state that we've been seeking our entire lives or for centuries? So as I mentioned back in the 5th step, that happiness is connection. I want to talk about how happiness through the 4 C's, this is Dr. Lustig's research again, and to expand on these principles through providing the 4 areas that have been proven through research to stimulate the production of serotonin. So the first step towards happiness is to connect. Now, that's that interpersonal connection that I mentioned before. For example, for the pleasure-seeking behaviors, individuals will seek pleasure on their own, right, without anybody, solo. But when it comes to being happy, it's cultivated through interpersonal connection. It's being with others. It's being face-to-face. It's that one-on-one, right? It's reading that nonverbal body language that builds up in our empathy when we're trying to communicate someone. And everyone saw that during the lockdown. When you're, your frontline workers, working with individuals who are in your PPE, trying to communicate empathy and warmth while being covered head to toe, you still were able to resonate that through your eyes, through your gestures. That's what we do, and it's connecting with someone. Even when family members couldn't be with someone on their last 9 days, you were able to then deliver what you could by being present with someone at that time. And that's that connection that people crave. Another physical human or animal or nature, that live other being to be there so we feel grounded and connected. When we have these interpersonal connections, this activates our serotonin, and that's triggering all our neurons and all our receptors. And again, this serotonin plays a vital role in creating these positive moods. Serotonin is secreted when we feel significant. During that isolation or state of sadness, serotonin levels become lower. So we are going to always have this increase and decrease in our bodies. The more stress that we experience, the more sadness, the more isolation. But we need to be conscious to build up our serotonin reserve. And first step from the 4 C's is to connect with others. This interpersonal connection, people, pets, nature, spirituality. It's the act of connection that stimulates the serotonin. Some may argue that like through social media, yeah, I'm connecting, so isn't that connecting? But I ask you, really, is that connecting through social media, just using your phone and just looking at an app and touching? If that is connecting, then why did we see so much depression increase and suicide ideality during the pandemic when everybody truly was physically distant from each other? When the use of social media increased, we actually saw an increase in the other negative emotions. So really, connection is the key. The next one I want to talk about is to contribute. Now, to contribute means to give something outside of yourself, right? But yet, this is a forum of healthcare providers. Your practice in life and your profession is to provide, to contribute, to give. But at the same time, I want you to be mindful of this. We also need to allow people to give us something. I hope I can see some head shaking, so people going, yeah. As I mentioned earlier, the gift is in the giving. And as healthcare practitioners, providers, we usually do the giving. But how much of us really let someone give to us? When someone offers you something, really, it doesn't matter what present or gift or task you're receiving. What matters is to that person, they are contributing to you. And they are now striving to increase their serotonin that way. So it is the other person too who needs to share whatever they have in that participation. This contribution is what matters. And that's what the gift is. Any contribution truly matters, no matter how large or how small, as you contribute to your family, your job, in the micro, meso, macro realm. People volunteer, provide any kind of service, philanthropy. The key is just doing something outside of yourself. And that's what happiness is. So for those of you who continue to give all the time, to help contribute, allow someone to contribute to you. Let them at home make you a cup of tea. Let somebody, do something for you, minimal or small. Let them earn their contribution, serotonin, and you just receive, because, the two of you are both winning. The third C is to cope. We all look towards coping mechanisms, right, to reduce stress. So if you want to just put in the chat to share with everybody, how do you cope? What do you find yourself doing just to catch your breath and cope with what's going on in life? As we reduce our stress, also I want to let you know that that is also increasing your serotonin. So any kind of coping and reduction of stress that you do, you're gently increasing that serotonin. But the few that I want to talk about right now is first to allow our bodies to rest. And first and foremost way we want our bodies to rest, and a lot of you ask this to your patients on your assessments, is how much sleep do you get? It's that simple, it's sleep. Our serotonin increases if we get a good night's sleep. And isn't that interesting? What has been found through research that has impeded our sleep over the past 10 years is the increase that we have in electronic devices. The past 10 years, they've done surveys, and people have had a reduction in sleep because they've increased in electronic devices. They take them into the bedroom. They have them next to them when they're trying to rest. It's those blue lights, it's those social media alerts, it's the cell phones, all computers, all these mechanisms, and this bright light is just interfering with our ability to sleep. So that's something that has gotten very interesting, that people turn to this to help them sleep, but it's not, it's hindering sleep. Another coping mechanism found to increase serotonin actually is our beautiful sun outside, or any kind of, bright sunlight. For example, those who suffer from seasonal affect disorder, SAD disorder, where you have the seasons where there's the minimal amount of light exposure. We're coming out to that soon in the fall. This, the bright light though, will counterbalance these effects of depression, and that will help also increase your serotonin. So we need sleep, we need some sun, and one of the third strategies of coping is exercise. We can improve our mood, as we know, through exercise, because it does release endorphins, and releasing those exercise endorphins are also going to increase our serotonin. Now, the fourth C to increase our serotonin and to increase our happiness is something, yes, as simple as cook. But cooking has so many layers to it. Just give me a minute to expand on this. When you cook, it's interpersonal, right? So we're getting that connection. It also has cross-cultural connections. Think about it. We eat every day, right? We must prepare a meal to sustain our bodies each and every day. And when we do that, and when we do it for others, that builds up the serotonin and increases our happiness. Even when you have meals that are surrounded by perhaps loss, by death, when someone dies. Traditionally and culturally, a lot of people will meet around food. They will go out to eat. They will bring food to, the home of the person, of the bereaved one. People join around food for multiple reasons. Happy reasons, day-to-day reasons, reasons of loss, even times of trauma, times of pain. But most find respite and some solace in just preparing the meal together. So I'm not looking for pleasure of eating. I'm talking about just in the act of preparing a meal, having that connection, and even sitting with someone just in silence. You're connecting, you're coping, you're contributing, you're sharing that with someone. And that's what cooking does. There's an ability to cook. There's a sense of pride for those who are aging into losing some independent life skills. They want to hold on even to the slightest bit of cooking, and that joy of just being able to prepare themselves, a cup of tea or coffee or a piece of toast is empowering to someone when they're losing a lot of their abilities, to prepare and to share and to give. This is where happiness truly lies. Again, it's not with the food or the eating, but in the preparing, time spent together with someone, that connecting, coping, and contributing. It's interesting because neurologists have also found that there are specific foods that can increase serotonin organically. For example, tryptophan. It's found in fish. It's found in flax and nuts, seeds, omega-3 fatty acids, soy, beans and lentils, and all natural holistic foods. They stabilize neurons in the brain, so the neurons are less likely not to die. So now just thinking about focusing on these 4 C's, along with the 7 components of happiness, are the key takeaways I want to share with you today. Another thing I want to share with you is that as healthcare providers, we're grounded in a strength-based perspective. Just similarly to serotonin, and happiness is also grounded in strength-based perspective. We want to focus on what someone's abilities are to help empower them to continue on each day. So even when patients present to us with a trauma, right, or a devastating personal issue or a disorder, we will still need to screen them for their strengths. Similarly, we need to screen for happiness. Yet we must do it in a way that doesn't diminish the pain that they're experiencing. So one tactic I always use when I'm working in sessions with patients is I love tools. You have your traditional, if you're, EPIC, you have your assessment that you have to do, but I always like to introduce an exterior tool. And these strength-based tools aid in soliciting the topic of resilience and allow it to surface, even when someone's suffering. So as a social worker, I love evidence-based tools, and I have several tools to share with you. And I want you to focus on the how-tos in attaining happiness. These tools are available in the PowerPoint that you received from Kendra earlier prior to my presentation. I have the links to the tools in the reference section in the back. So please feel free to download the PowerPoint and go right to the reference section and try the different tools that I have. But first, I often review and use a tool on myself before I use it with any kind of patient. So just please lead with that task. First practice on ourselves, find out how you respond viscerally and non-verbally and verbally to the type of questions. And I just hope this is something that you'll try out on your own. Choose the ones that are so authentic to you and it will assist you in your therapeutic approach with your patients. But I think this will also be a great avenue for you to try and practice providing another form of happiness for your patients. So in addition to tools, there's also kinesthetic practices that we can also engage in. And a kinesthetic practice that I often use in therapy is mindfulness. As I mentioned, hopefully some of the practitioners do practice brief guided meditation with some of your patients who might be experiencing, a visceral response or carrying in a lot of negative energy. Mindfulness really is something that is duly practiced through all disciplines. It's in our interprofessional self. And it's an awareness that emerges when we pay close attention to ourselves. We pay close attention to our thoughts, our physical body, our moods. We have to be on purpose with intention. And it's about being present in the moment. But more importantly, about being present in the moment, it's also not being judgmental about anything about you, just to be as simple as you are. As simple as we started off with the meditation, as paying attention to your breath. As we did in the beginning, just close your eyes. And when you close your eyes, you're less distracted about the external world around you. And then you can truly focus on your breath or lower your gaze. But try it. Just take a deep, slow breath and bring it into yourself in the present moment. And just announce to yourself an intention for this moment. And for example, right now, I want to feel peace and I want to feel centered. And when I say it aloud, when I breathe it in and I exhale, I'm connecting with myself in a kinesthetic way, physically, emotionally, spiritually. And just try that. The breath is our #1 strength. As long as you use your breath in any way you can, even medically, it is so curing for many ailments that people endure. The second premise of mindfulness is to be aware of how, our bodies feel physically, to be aware of any tenseness that we might have in our bodies, like tightness in our shoulders, or from our feet or our hands. Some people, have those tightness of the chest, or just the neck and shoulders, or just any type of visceral reaction, or sometimes like you cross your legs and they jitter, or your teeth grind, right? Or whatever it is. When you take that breath, scan your body. Adjust yourself to be in a silent, motionless state. That also helps you get into the state of mindfulness. Another way to be in this mindfulness state is to treat ourselves as we would a guest. Just think about it. When we have guests or new people in our lives, right? At times we actually treat them better than we ever treat the ones around us or ourselves. We'll do more for others than we do for ourselves. So just remember these words. You owe it to yourself to be treated as good as anyone. If you find yourself or your mind wandering to back, the best mechanism to help bring you back into the moment is just get your breath. Draw all your attention into breathing, holding your breath, exhaling it, and that will definitely distract that busy mind of yours and bring you back to the focus in the here and now of the world. Just think about it. Using your breath is one of your greatest strengths. So take a few moments of your day. That's all you need. Just to be mindful is the first step. And that will then lead you towards more compassion of yourself. It might seem a little counterintuitive, but people learn mindfulness and healing tend to forget themselves. And all that great caring energy that is projected onto others really needs to be brought back to the person who is delivering it, and that's themselves. So all this mindfulness and all this compassion and all this time you're spending as a practitioner healing and helping others, please know you deserve that and more for yourself. And we shouldn't look to others to do it for us. It starts with us. So please be compassionate with yourself. Share this self-compassion session. There's a wonderful tool, again, that I have in the PowerPoint for making that happen, because suffering in life is universal. We're all experiencing suffering in any capacity, shape, or form, minute by minute, hour by hour, day by day, or month by month. But we have to find something to use this self-compassion. So it should, to simplify it, to interfere and interrupt the suffering that we know is waiting for us, or the crisis that we know is waiting for us. Build up your serotonin reserves through these mindful practices. And please just keep that in mind so your reserve grows and all the providing that you do for others will not deplete you. Just want to know if anyone does practice mindful practice, if you can put it in the chat and share with others what you possibly do. If you do meditate, or take a nature walk break, or just plug in and listen to a special song, or just focus on some sort of picture, or even aromatherapy. Do you have like an oil that you just put on your body and you just smell and you know it's there? What is it that you do that helps you just center Draw that breath, get yourself ready to continue this provider work that you do. Just put it in the chat if you can, that would be great. For those of you who may want to explore other resources from self-cares, I just want to share with you, I'm from Rutgers School of Social Work, and we have to work on a macro level to provide our self-care tools externally for all the providers in all shapes or fashion. So as we integrate our micro practices into the meso, our macro forum is an integral core competency that we always strive to practice. So the Rutgers School of Social Work follows the macro practice of giving, along with other schools of social work, for example, Buffalo. And we have these wonderful websites that have a lot of wonderful provider material that is interprofessional. It crosses the spectrum for all professions. Anyone who's a provider, teachers, fire, doctors, nurses, social workers, therapists, individuals in the rural community, in the urban community, anyone who's dealing with another person or living being. We need to know how to care for ourselves in order to keep going. So definitely check out these websites also in the PowerPoint, because we have to also share how we practice what we preach. That helps us reinforce to practice what we preach. A lot of you say, Mary Beth, listen, I have patients to see, I'm a practitioner, I have responsibilities, I don't have time for formal exercise, which is one of the 4 C's to get out there and to exercise. So even stopping with your breath, you can even do something in your chair. There's chair yoga through Pinterest, just Google it. If anyone does practice yoga, you can do certain stretches, and 1 or 2 minutes at your desk will really be transformative. Like other forms of exercise, but seated yoga can help improve your mood. It can help improve your confidence, and it can also relieve anxiety and depression. Traditional yoga poses can be replicated as a sitting yoga pose or yoga stretches using your chair. And this makes the chair yoga both suitable and enjoyable for individuals at all levels of experience. So just focus on the movement, your breathing, and how your body is reacting to this exercise. That creates a moving meditation, and it promotes relaxation. It reduces stress and improves mental clarity. So once you begin practicing chair yoga, you'll start to feel, a sense of ease and relaxation flow through your body. Then over time, you'll definitely notice the tension that once overtook your muscles and joints. It starts to begin to release, and the basic tasks of daily life are once again possible. I'm always on the computer, so I always do a lot of upper body stretches, putting my arms and palms very close to my ears. I'm doing a back bend on my head and doing twists like this in the chair. Even for individuals who are permanently seated, this is another form of stretch, of upper body movement to help invigorate someone. So again, working with individuals who are permanently in a seated position, practicing this on our own, we can then guide somebody, demonstrate to somebody, model it to somebody about what to do and the benefits of it too. So now I want to just jump back to practicing on ourselves first. And this is always the beginning of our journeys in engagement. We're going to help achieve, sustain, and cultivate these positive emotions when we first practice on our own selves. So I want to invite each and one of you to practice posting this short loving kindness guiding meditation right now in your space. I have a script right here on the screen. I hope you can read it. And I would love to invite someone to unmute and then post this and read this loving kindness meditation for all of us right now. Others, you can mute yourselves and read it aloud at home. It's really about noticing your own authentic tone, realizing your pace, your words, enunciation, and pauses. So it's great to download a meditation or a guided meditation and through the apps and use it in the sessions. But please try it on yourself first and get your own clinical voice going, with your kind intentions. So would someone love to unmute and please read this while the others stay muted and read it along, and let's see how it feels. I invite anybody to unmute.
Before I invite myself, I'll welcome one of the panelists speakers. Okay, I'll do it, Mary Beth.
Thank you.
No problem. Okay. Loving kindness meditation. May I be healthy and strong. May I be safe and protected. May I be peaceful and free from mental, emotional, and physical suffering. May I be happy and joyful. May I be patient and understanding. May I be loving, kind, compassionate, and gentle in my ways. May I be courageous in dealing with difficulties and always meet with success. May I be diligent and committed to my meditation practices and to helping others along their spiritual path. May my true nature shine through and onto all beings I encounter.
Thank you, Kendra. Thank you.
Sure.
I appreciate that. How did that feel, if you just mind just saying, or if anyone practiced in the chat, how did that feel just saying it aloud? Or hearing her voice, your very calming voice, very wonderful words, and they really resonated. And that's what it is all about, just really feeling the positive energy, hearing someone's attention through these wonderful words, and just being in the moment, connecting with someone. Try it on your own, practice it on your own, and sharing it with someone in need. And that's another way of contributing and giving, just being in the moment with someone. So in closing, I just want to remind everyone that a key aspect to this mindful practice is gratitude. And that's that intentional gratitude, that we are making a mental note, thanking ourselves and those around us and any higher being in the universe for this moment that we are in right in the here and now. You can even add a list of abilities that you have that you may be taking for granted. We have abilities every day. I have an ability to navigate my body. I have my use of my appendages. I have my senses. I have my organs, my sight, my ability to eat and swallow and move with this physical agility that each one of us have in this life. That's something I'm very grateful for. And as we remind ourselves of the items, the people, and the abilities that we possess, it's our intervention and our intention takes us a few moments away from any negative thoughts or negative self-talk that would traditionally jump in. Back to that first few slides I showed you about that beautiful beach and that pile of rubbish. We want to stop and just be grateful to ourselves, and that will help ground us, increase our serotonin, and stop the negative thoughts from impeding us during these few moments. So just another suggestion is, I would suggest is to have a gratitude list. Just orally review it once a day, jot it down if you're a journaler, make it all a little private app in your phone, but just start off with one item that you're really grateful for in this world. And then as your practice grows, the more contemplation of gratitude will evolve. Practicing gratitude is an act that increases our serotonin. Thus, it places us towards a desirable state of happiness. I'm a realist. I know that every moment in life is not going to be pleasurable or happy, but I'm mindful that preparing myself, and I hope that you're mindful about preparing yourself to strengthen your resolve and practice these strength-based coping strategies. Because when we encounter, and we're due to it, bleak, traumatic, depressing, anxiety-ridden, or devastating loss, in which we all encounter all the time, when we practice positivity, it better prepares our emotional core to withstand what we are experiencing. while striving to counter the effects of that negativity through positivity. It's about building up that reserve. It's through our experiences and our practices that we're able to circle back to a better place. So practicing mindfulness, practicing meditation, pursuing happiness instead of pleasure are all wonderful exercises in promoting good health. It's preventative care, and it's something that we all look forward to achieving. So I want to thank you for today.
Wow, thank you so much, Mary Beth. What a way to end this wonderful seminar. I'm pretty sure we all can take something amazing away from what you mentioned today, and using the tools that you provided. I know that I can. I'm especially practicing meditation. And, you know, while you were talking, I was actually doing the chair yoga. You know, that's why, you know, sitting here for a little while. So that will definitely benefit a lot of us who often sit in front of the screen majority of the day. So thank you for such a wonderful presentation. Everyone is giving their feedback about it, how excellent your presentation was, the affirmations that we can use on a daily basis, because sometimes it can be a little tough. We can have some good days and we can have some bad days. So those affirmations, it's definitely helpful. So lastly, let me share my screen. So I just want to thank all of the speakers today for providing some great information, your feedback, the panelists. Thank you so much for taking your time out today to share wonderful information that all of the attendees can take away. But we also need your feedback to the attendees. So here is the QR code that you can use to actually get access to the evaluation along with the link. In order for you to receive the credits, you have to fill out the evaluation form. If you have any problems, feel free to send me an email. But here is the link and the QR code. Again, I'd like to thank all of the speakers. Thank you everyone for joining today. And thank you for being patient with us. Sometimes technology can get away with us. And that's beyond our controls. But thank you so much. And I really appreciate the speakers for joining us today and providing wonderful information. Okay, thank you again. And that concludes the webinar.
Thank you, Kendra.
You're welcome. Thank you.
You did an excellent job.
Thank you.
Thank you, Agatha. Thank you.
Thank you.